I'm very, very honored to be asked to talk. And I'm just going to start off really by presenting a case of amyloid that we thought was localized that we got very, very wrong. And I think it's a really important diagnostic challenge. And then I will talk a little bit about localized amyloidosis in general. So this case, it was an 81-year-old professional or ex-professional boxer. He had a 2-year history of hematuria. And in 2010, in October, he presented with a severe episode which took him to his doctor. He was referred to the urologists, and he had a cystoscopy. And at the cystoscopy, they found several abnormal lesions in his bladder. He had a biopsy, and that showed amyloid. And then he was referred to us at the National Amyloidosis Center. He had a poor urinary stream, urinary frequency. His frank hematuria had completely settled, it had gone. He had no dysuria, no fevers, no symptoms of systemic disease in any way. And in particular, he wasn't breathless, he had no edema, he had no nerve symptoms, he was completely well. He had a past history of bowel polyps and multiple polypectomies, and there was no family history. He smoked a little bit, drank a little bit of alcohol, and his only medication was simvastatin. He was examined. There was nothing to find on examination. No neuropathy, no macroglossia, no suggestion of systemic disease, no organomegaly. Cardiovascular examination was normal. And these are his investigations at baseline when we saw him, and really nothing. We thought the NT-proBNP of 31 in an 81-year-old was probably acceptable. There were no markers, as we've just heard, of a plasma cell dyscrasia. So light chains normal, no paraprotein, no Bence-Jones proteinuria. So we went on and did an SAP scan to look for visceral amyloid deposits in the major organs, and there were no amyloid deposits in the major organs. He had an echocardiogram, and he had mild diastolic dysfunction, which we thought was acceptable for age. No evidence of amyloid was our conclusion. He had a biopsy. We reviewed the biopsy. We confirmed amyloid on Congo red staining, and when we stained with a panel of antibodies, including anti-kappa and anti-lambda, there was no immunospecific staining. So our diagnosis was one of localized AL amyloidosis of the bladder. And as I said to you at that point, he had no symptoms, he was well, 81-year-old, so we thought the possibilities were either to observe him alone, not sure about how often he should perhaps have repeat cystoscopies. Does he need repeat cystoscopies? That's a question. Or to do cystoscopic removal of any other lesions in his bladder. He'd only had a biopsy up until then. Or to give intravesical DMSO. I apologize, that should be a no. So there's a little bit of literature, no good studies, but there's some case reports of improvement, clinical improvement with intravesical DMSO therapy. So those were our options. What would you have done? Hands up for anyone who would have done nothing. And cystoscopy and remove the lesions? Okay. So we did nothing. maybe that's our way, but we did nothing, and we reviewed him 6 months later, by this time 2011, and he had no change, no frank hematuria. His investigations were all exactly the same, so we thought he's fine, and we thought we will just review him 3 years later. And in the meantime, further investigations were, in his absence, we were doing some studies with proteomics, and we put his biopsy through some proteomics. And these are results of his biopsy. I apologize, it's probably a bit difficult to see, but what you can see is you have SAP, ApoE, and ApoA4 there, and that's what we call the amyloid signature. That tells you that you've chopped out amyloid if you have those 3 proteins. And you can see that the second protein there is transthyretin. So we had transthyretin, and we didn't have any kappa or lambda light chains on his biopsy. And this was the coverage, the transthyretin coverage. This is the coverage of the protein. The peptides in red are the ones that are covered by the proteomic analysis. So 33% of sequence coverage, quite high, reasonably high. So we thought this is interesting. He came back in 2014, and by that time, he'd had a general decline in his health. He wasn't complaining of dyspnea, but he had a bit of lower back pain, and he was walking with a stick, His BNP hasn't really changed. His echocardiogram showed 12 millimeter walls, still very mild diastolic dysfunction, preserved systolic function, but no definite amyloid was our conclusion. We then went on to do a DPD scan, and he had Perugini grade 2. We've heard about the DPD scans and the Perugini classification. Perugini grade 2, abnormal cardiac uptake, and when we sequenced his transthyretin gene, it was wild type. This is his DPD scan, and you can see it's bordering on grade 3. It's 2.5 to 2 3/4, maybe. So the final diagnosis was not one of localized amyloid, and I apologize, I'm not talking about localized at all, but it was actually CNAR systemic, which has recently been renamed as wild-type transthyretin amyloidosis. So it's just an interesting case that presented with bladder amyloid and didn't present with cardiac disease as these patients are supposed to. We then went back, looked at all our bladder amyloids. So we thought we'd look at all the patients we had with so-called localized bladder amyloid, review their immunohistochemistry, stain with an anti-TTR antibody, which we didn't do routinely for bladder cases, do proteomic analysis, and do some DPD scans. We had a total of 82 patients, and in fact, we found TTR-type amyloid in 14, so 17%, nearly 1/5 of the patients had TTR-type amyloid in their bladders. The median age of the patients with TTR amyloid was 78. 6 had a history of bilateral carpal tunnel syndrome, which many of you will know is very common in CNAR systemic or wild-type ATTR amyloidosis. 10 out of 14 had symptoms of breathlessness. 6 AF, atrial fibrillation. None had visceral amyloid. We don't tend to see visceral amyloid on the SAP scan in wild-type TTR amyloid. And all 14 cases, when we went back and did DPD scans, had abnormal cardiac uptake. So they all had cardiac amyloid deposits when we went back and did their DPD scans. And the echocardiograms were said to be characteristic in 8 cases. So I suppose this case, although it's not a case of localized, and I apologize again, but it just highlights the importance of typing amyloid, the amyloid fibril really in all cases of amyloid. I should also say we've got some patients who've presented with isolated gastrointestinal amyloid deposits where we've thought they've probably got localized AL, and we've found the same thing. They have TTR amyloid deposits. So I think that wild-type TTR amyloid deposits can probably deposit pretty much anywhere in the body, I suspect. So it's just an interesting case. So let me just come back to localized very briefly, a short bit on localized AL amyloidosis. So these are the routine investigations that we do at the National Amyloidosis Center in the UK. So we do look for plasma cell dyscrasia. Routinely we do biomarkers, SAP scans, plus or minus DPD scans in any patient with cardiac disease, an echocardiogram plus or minus a CMI in a patient with cardiac disease, an MRI, and review their histology, immunohistochemistry, sequencing of genes on when we think it's necessary, and obviously bone marrow biopsies. And so I'm presenting data that Frank Bridoux, the eminent Frank Bridoux, really collected. So as ever, I'm presenting someone else's data, and he's not here to take the credit. But essentially what he did and what we did is we looked retrospectively at all patients who were referred prior to this date and who fulfilled these diagnostic criteria. In other words, they had Congo red histology, negative AA, negative TTR on immunohistochemistry. They didn't have involvement of those particular organs, had a negative SAP scan apart from the involved site, and amyloid deposition in a single type of tissue histologically. And it was a retrospective analysis, and we just used those criteria to see what the clinical course and outcome of those patients was. There were 206 patients, that was their median age, and interestingly, 25% of them had a systemic clone. A significant proportion of those had a different isotype between the type of amyloid, immunohistochemically, and the clone, telling you that the systemic clone was not responsible for the amyloid. A small proportion had Sjögren's syndrome, and these were particularly patients with lung amyloid who had underlying Sjögren's syndrome. The histology, well, I told you that this was part of the selection criteria, so obviously it's 100%. In fact, positive immunohistochemistry with anti-kappa and anti-lambda was only 62%, so 38% had no immunospecific staining. About 15% had monoclonal B or plasma cells within the biopsy sample. So this is not in the bone marrow, this is within the biopsy sample, telling you that they've got a local monoclonal production of light chains, probably with surrounding amyloid. And then 23 cases had also had additional biopsies, of course, which didn't show amyloid elsewhere. They'd had biopsy from different organs. And we did some genetics in 52 patients who we suspected could have another type of amyloid, and we found one, what turned out to be an incidental lysozyme mutation in one individual. These are the organs that were involved. So, as you can see, the vast majority had laryngeal or lung, urinary tract, skin. I mean, these are no surprises to any of you. I suppose the ones to mention is that in the patients with lymph node amyloid, a higher proportion of those patients had a systemically detectable clone. And whether we should be calling lymph node amyloid localized is difficult. I'm not quite sure. I think those are patients to watch out for, as it were. These are the treatments that they receive, and of course this is summarized. I haven't got time to go all through the individuals, but the bottom line is that only 57 patients received any specific therapy at all. And this is despite 66 months of median follow-up. So the median follow-up in the group was 66 months, and only just over half needed any treatment. And most treatments had either excision or laser resection or excision by surgery or by endoscopic methods, and some had radiotherapy, DMSO for a few of the bladder cases I mentioned, some steroids and stent insertion in a small number. 10%, in fact, did receive systemic chemotherapy. What were the outcomes? Well, I told you the median follow-up was 66 months, and the minimum follow-up you see there was 18 months. And what you see here is that in the treated patients, the majority did improve, and even in the untreated patients, a significant proportion improved. In the untreated patients, the vast majority was stable, and in fact, the patients who got worse was a relatively small proportion. Overall, it was only 20% of patients with that long follow-up that got worse. So this has a very different prognosis from systemic amyloidosis. And at Sensor, only 16 patients, 8% had died, and only 2 of those cases, their deaths were attributable to amyloid. So it's just to make the point that this is really a very benign disease compared to the systemic amyloidoses. So to summarize, the diagnosis of localized AL amyloidosis is not straightforward. I think we need immunohistochemistry plus or minus proteomics on every case. And obviously, this is only available to us, but obviously what one needs to try and determine is that there's no disease outside the presenting organ. DPD scans can obviously be helpful if one suspects TTR amyloid. We've heard earlier that the TTR immunohistochemistry is not perfect, and I suppose if there's a lot of background or one isn't sure, that's when proteomics may be helpful in that situation. A significant proportion of patients with localized AL amyloidosis don't need treatment, and those that do are generally treated with local measures, either endoscopically or resections, and generally the outcomes are very good. I'd just like to thank Frank most of all, who did most of this work, and as I say, I'm just taking the credit for his work, and thanks very much.